Which one? Norepi. And I look these up every time before I give this to make sure something has changed. Septic, cardiogenic, and neurogenic first-line vasopressors. Norepi. I'm not going to ask you about the second one, but the second-line pressor for cardiogenic is vasopressin, not dobutamine. That did change. First line for epinephrine. Thank you. First line for anaphylaxis, epinephrine. And I know that y'all haven't been around me enough to understand my sense of humor. What did that mean? We don't give it, unless we're in a zombie apocalypse. So, you will see some places put dobutamine like as a third line, but I'm not worried about that. I want to know the first line vasopressor. Guys, I know y'all are stressing about this test. Hold on just a second. So, I know that the test breakdown says hemodynamics. The only number you are responsible for is CVP, which stands for what? Central venous pressure, which is what? Which represents what? Preload and fluid status. What is your fluid status if you're hypovolemic? Your CVP is going to be low. If you're hypervolemic, you have CHF and it's backing up everywhere. What is your CVP going to be? 15. Y'all just did what? Hemodynamics. This is the type question I'm going to ask. Guys, I'm not asking you the numbers. And I know when I say I don't care about the numbers, I do. If you in the CV ICU, the medical ICU, and you have a swan, does anybody in here know how to do a swan? I don't remember. What good does it do me? Nothing. I want you to look at this patient and you can figure out which one of these it goes with and what is their ultimate what? Cardiac output, perfusion status. Ready, set, go. So, I gave y'all medical terms. Cardiac output was one. What was the other ones? SVR, which is what? Systemic vascular. The patient's blood pressure is 200 over 170. Which one's elevated? Blood pressure. Which one's elevated? Systemic vascular resistance. If your blood pressure is through the roof, how much blood is getting out? Your cardiac output goes down. Your perfusion status goes down. Y'all just did hemodynamics based on what's wrong with the patient. And before you do interventions, you did what? You did your assessment. If you don't do your assessment, you don't know what kind of shock they're in. If you didn't do an EKG, you wouldn't have seen that STEMI, right? What kind of shock? If they're having a STEMI. Cardiogenic. If it was a trauma patient, they couldn't move their legs, heart rate's 20. Neurogenic. What's the first line vasopressor? Norepi. Neurogenic shock, massive vasodilation, hypervolemic. All their fluid has gone out. So it's hypovolemic. I know it's neurogenic. All their fluid goes out. What's their CVP? Low. What's their cardiac output? Low. Their MAP is going to be low. That's the one thing we look at kind of to fit. What's their Foley going to have in it? Nothing. Do you see how everybody, y'all just did this. You just walked through this case scenario. This is what it means to be a nurse. I walk in and I've got all this. And I'm like, oh my God, what's going on with the patient? Oh, they've got pneumonia. Oh, and guys, this is, we had a patient yesterday. And it wound up, we've been in the room all day and oh, they got COVID. Allison sees I'm looking at her. She ain't looking at me. And I'm like, she's been in the room all day. She had COVID. She's got a temperature of 104. What shock? Septic. Now, what's the difference between sepsis and septic shock? The onset of, just guess. No, it's not symptoms. It's one sign and symptom. And it's measurable. It's not necessarily temperature because can they not have a fever? A drop in blood pressure. Because if I've just got sepsis, I've got tachycardia, I've got tachypnea, I've got maybe even hypertension. There is an insult to the system, right? The body is in which one? Sympathetic or parasympathetic? It doesn't matter what the insult is, whether I'm running for the bear, whether I have a really bad infection, my body is trying to save itself. Fight or flight. Every sign and symptom you see with that, tachycardia, tachypnea, originally hypertension, maybe a little bit. Are you going to go pee? Nope, it's going to hold on to everything. And so a patient that's really, really sick in septic shock, we kind of have to worry about what? Their gut's shutting down. And maybe even not starting back up. Sympathetic is in effect. Now, can it stay? And y'all can believe me if you want to. Every one of y'all is going to get sick after graduation. Why? Y'all had been literally in fight or flight for about a year. And your body's cortisol levels are in the toilet. And I had so many of my students, Miss Thornton, I got sick. I said, I told you, I got sick too. Y'all are not stressing me out. The writing test questions are stressing me out. Guys, that's hard. And it wasn't until I met Dr. Wilk that I figured out I'm not very good at it. She's taught me a lot though. If you have a patient in septic shock, MAP is 50. Temp is 104. White blood cell count is 20,000. If you got that and I didn't say they're in septic shock, what would you say they're in? Septic shock. First line pressure, norepi. You expect their WBCs to be what? Elevated. How much fluid are we going to give them? A lot. 30 milliliters per kilogram. Guys, that's a lot. Your assessment and what's going on with the patient guides what? Interventions. If I didn't know their white blood cell count is high, if I didn't know they had a fever, if I didn't know that their MAP was low, and they're in septic shock, and they're like, oh, they're in hypovolemic shock, go get them some fluid and red blood cells, and you walk in, you're like, is that the right interventions? It's not. In the real world, how many people are usually in this room? At least more than what? At least more than one. So if there's more than one person, are we going to do a lot of this stuff at the same time? Yes. If you're in that room by yourself with a septic patient, what is priority? We're not talking about ABCs. Ain't nobody come to help you. What is going to treat the cause? Antibiotics. If you don't give antibiotics, they're going to die. Yes, we have, and everything is going to be in there that you need to choose. fluids, vasopressors, antibiotics. Guys, I know this is a test, and I know that when you get out, there's going to be more than one person in there, right? These test questions that Dr. Wilt has taught me how to write are just like NCLEX. You have to take it absolute face value. What's the cause? It's like defibrillation, they in VFib. I don't care what you do. You can stand on your head. It doesn't matter. Until you defibrillate, they're not coming out of that rhythm. That's real life. I can treat this all day long. I'm not going to give them red blood cells. I'm not going to better not give them epinephrine. What is going to treat the cause? Broad spectrum antibiotics. You might want to remember that. But is every choice that you will give them on there? Stop reading into questions. I'm going to beat y'all, every one of you. And we all do it. What are we talking about today? Respiratory failure and what? Vent and ARDS. ARDS leads to respiratory failure leads to death. There's two types of respiratory failure. Oh wait, stop. What is the respiratory system job?
Breathe in, breathe out.
Breathe in, breathe out. The air needs to go round and round. But I have to do what at the end of the day? If I get oxygen in and I don't have any exchange, that's a problem, right? Hey, that's a form of respiratory failure. Where does it occur? Where's magic happen? At the alveoli, we breathe in and out, 21%. The oxygen comes in, goes all the way down, trachea, right and left main stem bronchi, bronchioles, and then where's it go? Right here. What is underneath the alveoli? A vast capillary bed. This is where oxygen has made it all the way down here. What we want to see is oxygen goes in the bloodstream, goes out to the body. Carbon dioxide comes out and is breathed out. If there is any problem with this process, it's a bad thing. There's different things that cause and get in the way of that diffusion. There are two types. What might not cause oxygen to get in? What am I talking about?
Like a closed airway?
Yeah, I can't even ventilate. This is ventilation, not oxygenation, not respiration. I can't even get it down to where it needs to go. Right? Hypoxemia. Low in the blood. Anemia. You ain't got none of the things that you ate. Apnea. Without breathing. So either you're not getting the oxygen where it needs to go, or you're not getting what out. And guys, I mistyped this. It's not, it autocorrected. Hypercapnia, wait. That one's different. Is that right? It's not hypercarbic, it's hypercapnia. I swear the last one said hypercarbic. Yeah. Anyway, what causes this? It's a buildup of what? CO2. Huh? Won't breathe. What is this? CNS, central nervous system. It's in where? Brain or spinal cord? Give me a cause. Y'all been studying about it for 5 days. Neurogenic shock. If it has gone up the spinal cord and affecting all this, the brain ain't gonna say, I don't know if I should breathe or not. What is that affecting? Ventilation. What else? Won't breathe. COPD. That affects the diffusion. Overdose on what? We seeing it every day. Fentanyl, opioids, narcotics. They come in and they're breathing 2 times a minute. What's building up? CO2. If you're breathing 2 times a minute and the carbon dioxide is building up, how do you fix that? And every student nurse knows how to fix this. Breathe for them. How do you do that? With a bag. Guys, I feel like in this program, that is the most undervalued skill that every student nurse needs to know how to do. Period. I got to get a doctor's order for the Narcan. I ain't going to get nothing to bag my patient. If their O2 sat is 50 and they're not breathing 2 times a minute, you better do something, right? If they're breathing 2 times a minute, how much oxygen are they getting in? Let's say they have a bad heart. What's going to happen? Ischemia is going to build up, and they're going to have an MI. What kind of shock are we in? Cardiogenic. I wasn't getting oxygen in. I had switched from aerobic to anaerobic. My pH was 7.2 anyway. Now, what is it? 6.9. My potassium has shifted. Does everybody see what this is doing? Your cardiac output goes down. Your map goes, y'all just work through hemodynamics. Do you see what I'm telling you? You get these answers, and I'm not just talking about the test. You know I don't teach to the test. You can walk in their room right now as a student nurse. Do you go and order the Narcan? Nope. But you're going to know they need to give it. And you're going to know if they're in respiratory acidosis or metabolic. Right? If they're breathing 2 times a minute, they're not blowing off CO2. They've switched from aerobic to anaerobic. pH is going to drop. Now, you're not going to know the numbers, right? What is their lactic doing? Building up. You're still not going to know the numbers. How can you fix it? Breathe for them. That CO2 will go down. And after you start, when I do get the numbers, and we've been doing resuscitation, right? Gave them the fluids, gave them the antibiotics, gave them everything. Everybody gets whatever. How do I know what I'm doing worked? I'm going to draw another pair of ABGs. If my lactate was, they'd be dead, 19. What do I want it to be now? At least lower than 19. I mean, I want it to be like low. But what if I come back in there and it's 50? We're going what? The wrong way. Whatever we did not work. What is the definition of insanity? And expecting a different outcome. I'm going to run over there and hit my head on the wall. Oh, that hurt. I'm going to run over there and hit my head. Oh, that hurt. And then you're unconscious. If what you're doing, if what intervention you're doing is not working, you need to go back and do what? I need to reassess. Maybe I missed something. Maybe we didn't know they're septic. And then we send them for a chest x-ray and it comes back completely whited out with pneumonia. We didn't give them any antibiotics, but we're going to now. That might turn it around. You cannot decide what interventions to do if you don't do your assessment. And you know they're in respiratory acidosis. You know how to fix that problem. No, I don't know the numbers, but you know their cardiac output has gone down. Their MAP is going to be low, but you didn't know that until you walked in their room. I had to put these numbers on here, but this is not testable. This is criteria to be considered what? Respiratory failure. One of the last slides on here, because a student asked me, Ms. Horton, what's the difference between respiratory distress and respiratory failure? This is just the numbers. I gave you these just as a reference. This is not testable, so you can throw this out if you want to, but I want you to know there is diagnostic criteria. But you can figure all that out by looking at your patient and what you need to do, what oxygen adjunct you need to use. What does it look like? I know y'all sleep. Come on. What does it look like? You walk in the room and what? They're short of breath. What else? Increased respiratory rate initially. Increased work of breathing. They're in whatever their position of comfort is. If that's standing on their head, then they're standing on their head. Tachycardia, tachypnea. What nervous system is in effect? The body is trying to save itself. Can you stay in the sympathetic nervous system with extreme fight or flight forever? No. Sooner or later, what's going to happen? You're going to decompensate, right? You can't maintain it. Oh, what did I tell you the difference between sepsis and septic shock is? The onset of what? Hypotension. Initially, they're going to be hypertensive. If you wait, you can wait if you want to, until that blood pressure and that map drops. How far behind the 8 ball are we? You should have started resuscitation a long way before this, but nobody went in the room. They weren't in there when they were tachycardic and tachypneic, and they didn't put them on the monitor. What is this?
Retractions.
It is retractions. What other accessory muscles do we use? Huh?
Like the abdomen, really working it.
So it's where in adults? Substernal. Where else? Subclavicular is right in here. Nasal flaring. What do we see nasal flaring at most? With pediatric patients. I have seen adults do it, but you usually see that in peds. Where else? Intercostal. What are they doing? Every single. Do we normally use these muscles to breathe? Nope. And you will see it right here. It's called tracheal tugging. You better do something. How can you see all this if they got their clothes on? For the young lady, guys, I'm not telling you we just throw privacy out. If they're breathing 2 times a minute, we throw privacy out, shut the curtain. Now, we don't just say we're going to show everybody all your possibles. You can't assess what you can't see. If they're having this much trouble, that shirt has got to come off. And for the young ladies, what else needs to come off? The bra. I need to see in here. I need to see if they've got substernal retractions. I need to see if they've got intercostal retractions. If they have all of this, how much work of breathing is that? A lot. How long will they maintain that? Not long. What are we going to do? What are we going to assess? From the doorway, what am I going to do? I'm going to look at them, and guys, can you immediately tell sometimes sick or not sick? You're going to look up there, somebody put them on the monitor, they're breathing 60 times a minute, sick or not sick. You can just go ahead and say they sick. Folks don't breathe at 60 times a minute. And next time your child says, I'm going to hold my breath till I pass out. Ready, say, go. And they might pass out. Like, I have had parents tell me, my child is just stubborn. Your brain ain't going to let you not breathe. And then we come back. You ready to do it again? Go ahead. They won't stop. They'll get tired of it after a minute. Pulse ox. If they have the little nasal cannulas that monitor what? CO2. It's just an extra tool. There's no reason not to put that on, especially if it was a narcotic overdose and we don't really know what narcotic it was, and your patient keeps going back down and breathing 4 times a minute, and you have a new nurse and you tell them to go get the doctor, and they're outside waiting outside the door because he's on the phone. Why am I so concerned about that? If your respiratory system is shutting down, what's going to be after that? Your cardiac. And if they already don't have a very healthy heart, and they start saying, I'm feeling this fluttering in my chest, and they're having all these PVCs, the heart is what? Irritable. The ventricles are irritable. They're not getting oxygen. you're going to see a low ST segment. If the ST segment is low, you have low what? O2. You'll see that ischemia, the ST segment will be depressed. We keep going down this, multiple PVCs. Hey, they got a run of VTAC. Hey, they had another run. Guess what's supposed to happen? You're going to have VTAC, cardiac arrest, because the heart will not do without oxygen. Was that your initial problem? It was not. They need to be on the cardiac monitor. And sometime they're probably going to do a what? Even if it's not cardiac, they're going to do an EKG. What lab is paramount? And this is when they first get there. Because if I put them on the vent at 100%, when we draw them ABGs, what's their oxygen going to be? 560. That wasn't what it was when they came in. It was 50. What's normal? Huh? It's like 80 to 100. I don't know if they've changed that. It might be 60. I need to make sure that they haven't flipped that number. Anyway, if it's below 60, it's too low. What does that mean? They're not getting oxygen in where? The blood. You draw ABG from a what? Artery. Can you draw a BBG?
Yes.
Which is what? Is it going to have the same numbers? It is not. That is deoxygenated blood. What if you can't get an arterial stick? It's better than nothing, right? And you can base treatment on that. It is not as good, but it's better than nothing. What else? Why do I want this? What can you see on a plain film? Say it. Infiltrates. Y'all ever heard a word that starts with a C? Consolidation. What is that indicative of? Pneumonia. What else? What were you saying, Jess? If their heart is shifted, or if their heart is what? Too big. You can see cardiomegaly on there because the doctors, he like did this and he's like, oh yeah, their heart's too big. I'm like, okay. Why do I want this? I need a white count. What else? Patient's been in a car wreck. Abdomen's distended. What are they probably doing? Bleeding internally. Then my hemoglobin and hematocrit is in the toilet. What are they doing? Bleeding out internally. Oh, what kind of shock are we in? Hemorrhagic, hypovolemic. Their MAP is 20. What is their cardiac output? Are they in hypoperfusion, hyperperfusion? I don't even think that's a thing. Hypoperfusion. They are not getting oxygen and perfusion to some area. Y'all just work through all the hemodynamics of hemorrhagic shock. What's their preload going to be? They ain't got no blood. It ain't getting back to the right atrium. That's what a CVP monitors. What is their CVP going to be? 0.5. What's normal? 2 to 6. So, what if they had diarrhea and vomited for the last 12 days? CVP going to be? BUN and creatinine are going to be high. They ain't got no fluid floating around in there. All they got is the stuff. And what else is an elevated BUN and creatinine and a low GFR indicative of? Kidney injury. What did we say hypovolemic shock leads to? Multiple organ, and where does it go to? It goes skin, gut, lungs, kidney. We have progressed there. If we don't do something, even if we do something at this point, it might not make a difference. That is too far down the spectrum of bad things. EKG. Come in with chest pain, shortness of breath, nausea, vomiting. You're going to rule out anything. You go in there and they got a Big, huge ST segment elevation. Your troponin is 10,000. The last one was 20. And I'm like, he didn't have ST segment elevation until we walked out of the room. And then we were panicked and calling cath lab. ST segment elevation, troponin is way elevated. BNP was elevated. It was like 8,000. So what did they have before? Congestive heart failure. What have they got now? An MI. Their perfusion sucked. And now it really, and we can even say they came in with pink frothy sputum and their O2 sat is nothing. So they had developed what? Do you guys see what I'm telling you? You figured out immediately. I didn't even have to talk to them. Pink frothy sputum, what kind of heart failure? Left-sided. Guys, that's all that causes that if it's linked to their heart. Their BNP is through the roof. Now I did an EKG and it's got ST segment elevation. Their perfusion was already what? Bad. Now my heart's beating 50 times a minute. My O2 sat's dropping. My MAP is 20. What's their cardiac output? Do you see what I'm telling you? I don't need those numbers. Are they good to have? Absolutely. How many people in here know how to float a swan? I couldn't tell you. I did that years ago. Guys, that is complicated. Is what we just talked about complicated? Nope. What are you going to do for the patient? Oxygen. What else? It's hypovolemic. Fluids. If it's trauma. Blood. What else? If it's sepsis. Antibiotics. Do you see what I'm telling you? You did your assessment. You know their perfusion is bad. What does their skin look like? Maybe cyanotic if it's respiratory failure. What if they're bleeding? Pale. What if it's cardiogenic? Probably mottled. All those mean that they're in a state of hypoperfusion. It's just a different reason. You have to treat what? The cause. Or you're just throwing stuff out the window. I just put this on here for your knowledge. Does anybody know what a VQ scan looks for? It looks for little bitty PEs. This is nuclear medicine. Tenova does not do this. It takes a very specialized, and I'm going to say this wrong. It's the techs in X-ray. Do they call them radiology techs? Yeah. But they have to go to extra education to do this, and it's a strange machine. It kind of rolls around you. But if they ruled everything else out, and you're at a bigger hospital, you may see them do that. So this is a continuum if you don't do nothing. I'll quit cutting these wrong ones out in a minute. So the patient comes in, and they're in a little bit of distress. What's it going to look like? Tachypnic. You walk in and you hear a strider. You haven't taken their shirt off yet. What might you see when you take their shirt off? Retractions and what else? They're working out in the yard. They might be diaphragm. What'd you say? Who said it? Hives. Where do hives start? The core of the body. If you don't take that shirt off, you might not see it initially. But I walk in, I take their shirt off, I hear stridor and wheezing from the door, take that shirt off, and they have hives. Immediately, what are you going to give them? Epinephrine, IM. And that's a big NCLEX question. For testing purposes, I know that if you're not in the emergency room, one of the doctors has to order it. We are on the test. I want you to take this question at face. But everybody just answered this. And that question is important. What are you going to do? Hold on. If you don't give them the epi, is anything else going to matter? It's not. You can stand on your head, get the golden IV in. It doesn't matter. This is going to close off. Their lungs are going to close off. Airway. I ain't even going to get to circulation. Because now I don't even have an airway and I can't even do a surgical crike because it's swollen shut. Yes, ma'am.
So you have agitation, anxiety, listed under distress. Does that include hyperventilation, or is hyperventilation just kind of a separate? Like when people are hyperventilating because they're freaking out over a spider.
That's different.
I mean, is that gonna?
No.
Okay.
I'm anxious about my phobia.
Okay.
Does this say altered level of consciousness unresponsive? No. That's over there. Somewhere. What did I tell you the first sign and symptom of shock is? Anxiety. That might be important. Is that an altered level of consciousness? It is. That's not how she looked when I came in here. She's talking to me. She's kind of a little bit off. She A&O times 2. But I come back in and she's wringing her hands and she's messing with stuff. She's like, oh, I feel like I'm going to die. Anxiety. She is the sympathetic nervous system is trying to save itself, and it floods her body with epinephrine. That's what causes that impending sense of doom. That's what makes her diaphoretic. That's what makes her blood shunt to the inside. That's what causes the mottling. Your signs and symptoms guide what? Your interventions. You don't just go in there and say, I'm going to give them some fluids. Oh, they have cardiogenic shock. You just killed them. What is this sign and symptom and this? Sympathetic nervous system. Your body is in fight or flight. What is your blood pressure initially? It's going to be a little bit elevated. It ain't going to be 300 over 120 or 170. Your body's trying to save itself. Tachycardia, tachypnea. But what about this? Is it going to be bad delayed? But it's going to be delayed. What's normal? Less than 3 seconds. It might be 5. But is that a problem? When associated with all of these, yes. They might be pale. They might be mottled. Now, what's happening? We're getting worse. Now, I just said tachypneic. I didn't say above 60. How bad is that? That's bad. And as an adult, especially me, guys, I'm a lot older than y'all. I can't maintain this. Y'all can maintain it a lot more than I can. You cannot sit here and breathe at 60 times a minute and just maintain that. Your body is going to do what eventually? Wear out. And then it's going to do what? Quit. Here, you got retractions, modeling. Did I say air hunger? No, I said what? When I give you these questions and I say facial lacerations, I wanted to beat every one of y'all. Well, if you got facial lacerations, what if you got blood in the airway? Did I put, this is a facial laceration. But if I put multiple facial jaw fractures, what is it affecting? Airway. Stop. Don't look any further. You got your answer. I didn't say, now if I said patient has a severe facial lacerations and you hear gurgling, snoring, do you see what I'm telling you? I can't give you these questions without giving you a little bit, because then that would mean like 3 answers are right. That's not fair. And if any of these questions, y'all find 3 right answers and the whole class decides that, what do we do with that question? We throw it out and we rewrite it so that next time it's not so hard. What is happening? So I'm doing what? I compensated up to this point, and the onset of hypotension means I cannot compensate anymore. Hypotension, the map's going to drop. The CVP is going to drop. The blood pressure is going to drop. What happens to their cardiac output? Drop. What's a component of cardiac output? Systemic, and what else? Stroke volume. All right, I increased my cardiac output by increasing my what? Stroke volume. Body's trying, we're doing hemodynamics here. What if my heart rate's 250? Is that a good stroke volume? What's going to happen to my cardiac output? It's going to drop. Bradycardia at a rate of 30. What's my cardiac output? What's my map? Do you see what I'm telling you guys? And everybody in here is answering these questions. You know these answers if you will just stop and think through the situation. Well, what's next? If you don't do anything, they're going to progress down this. This one is a severe altered level of consciousness. In pediatric patients, you'll see what? Head bobbing and grunting. You better do something. Respiratory arrest. What's their cardiac output? What's their carbon dioxide level? High. If you don't do anything, are they going to switch to all anaerobic? Yep. What's their pH? Low. What's their potassium? 12. And what rhythm do you go into? Flatline. Immediately. They're not going to be moving any air. They might be completely Smurf blue, or they might be a blue-gray color. They're not going to be responsive. They're not breathing. I called Dr. Will and I said, do you think I need to put this on there? She said yes. So I did what she said. I'm not per se going to test on this, but we've already talked about this. If I've got a low VQ shunt, am I getting ventilation? You're not even getting the air in. Can air even get to the perfusion part? Hold on. If I've got pus from pneumonia. Ventilation, perfusion, and I don't know why they said Q and not VP. Ventilation. Am I getting air? Y'all say the words. Am I ventilating? Nope, I'm not getting air in and out. If I have pneumonia and pus all in atelectasis, Lord have mercy, all in my alveoli, I'm getting air to right here, but is it getting to the capillary beds? It's not. So I still got blood running through there, but what ain't getting down there to the blood? The oxygen. What's the problem here? I'm getting the air in, but I can't get it to the capillaries. And so, low oxygen in the blood, hypoxemia, which is a form of respiratory failure. Now, did I say that my CO2 level is too high? I did not. Might this lead to my CO2 level being too high at the very end of it? What's causing this problem? What's this? It's a blood clot. What kind of shock? Obstructive. Why? You can't get no blood over there. Oxygen don't go where the blood don't. I'm so getting that t-shirt. Are they getting blood on the other side of this? No. Their perfusion is gone. They're in obstructive shock. Cardiac output is going to go. MAP's going to. Do you guys see what I'm talking about? I know y'all are scared for this test, but I promise you, you can figure this out. These are what the case scenarios are going to be. I can't get blood where it needs to go. I'm ventilating just fine, but ain't no oxygen getting where it needs to go, which is in the blood. certain types of COPD. What happens to the alveoli in COPD? Especially if they smoke for a long time and smoke 4 packs a day. They're damaged and they constrict. So if half of my alveoli are damaged, which is where what happens? How much exchange am I getting? You're not. They can breathe in, but there's no exchange going on. Because once again, if they're just flat, I can't breathe through them. Or what do COPDers get down in their alveoli? Junk. What does nicotine do to your vasculature? Makes it hard and makes it constrict. What's their blood flow? It's not great. What does that affect though? Even if you get it down there, you're not going to have the exchange. All right, guys, don't overcomplicate this. Acute respiratory what? Distress syndrome. There's a malfunction where? At the alveolar capillary membrane. What causes it? What kind of shock is septic shock? Distributed. And what did I tell you the fluid does? It's distributed to the place I don't want it to be. And that's third spacing. Where else is it distributed to? The lungs. Can you breathe through water? Nope. And I got septic shock. I got pneumonia. What else is in there? Pus. And a massive inflammatory response is happening. The release of histamine, cytokines, and it causes what? My capillaries to leak. Now all my alveoli are destroyed. If the ones that are not destroyed are filled with water and pus, how much perfusion is going? None. That's what ARDS is. But ARDS leads to what? Respiratory failure leads to arrest, leads to death. So sepsis, trauma, pneumothorax, tension pneumo, flail chest, is that affecting the integrity of the respiratory system? Yep. Does every patient that has these things develop ARDS? No, they don't, and we don't really know why it happens to some people. What about this? Why burns? What? Their skin is gone, so they're probably hypovolemic. What about if I tell you they worked at a factory and the steam pipe exploded? Does anybody know how hot steam is? At least over 1,500 degrees. And if you're standing close to that, what just happened? You have a what burn? An inhalation injury, and it burns all the way down and destroys your alveoli if it's hot enough. Not only that, and I know y'all have no burns, but I'm trying to show you how this happens. If you're in a house fire, there's 2 gases that are released, carbon monoxide and cyanide. If we're going to get all that down in here, what's it going to do to the lungs? You're going to destroy alveoli, massive inflammatory response. You're going to release histamine, cytokines, your capillaries are going to leak. We started all over. It doesn't matter. It matters for the interventions, but the cause doesn't matter if it's leading you into ARDS at first. The alveoli are going to fill with what? Something. Fluid, infectious material, and they're going to collapse. What is a near drowning? What's the difference between drowning and near drowning? You drown and you die. Near drowning, you live at least for a little while. You might die later. So your patient come in from Signature Nursing Home, and they got tube feeding, and the nurse went in there and laid them down flat and didn't turn off tube feed. What just happened? Does all of that tube feeding belong down in your lungs? It does not. They probably just signed that patient's death warrant. Guys, you can't aspirate things and go down in your lungs, because sooner or later it just causes a massive infection. Here we are back to what? They're running a fever, their MAP's low, their cardiac output sucks. They're in septic shock. Do you see how this works? Now, and this is important. If you're in the room by yourself again, patient comes in running a fever, white blood cell count's 30,000, their MAP is 40. What is the priority intervention? Huh? No. No. If you don't give this, guys, I know there's more than one nurse in there. If you don't, yes, if I don't give this, they're going to die. If the patient is in VFib, I can give them wow. I can give them all the vasopressors in the world. I can give them epi. I can give them aniodarone. If you don't defibrillate that patient and get the heart out of that rhythm, what good have you done? They have a massive infection. Are you going to give IV fluids? Absolutely. A lot of them. Am I going to give them antipyretics? Yes. If their fever is 160, if y'all ain't never had a fever of 105 as an adult, it really stinks. It makes you feel terrible. They're in septic shock. They have to have what? You have to treat the cause. I know we're going to draw blood cultures. I know you're going to run and get the vancomycin. There's 6 nurses in there because their blood pressure's in the toilet. I know you're going to yell at the doctor, I need a central line. What is first line pressure for septic shock? Norepi. You are responsible for that chart. I don't want to know second line. First line for which shocks is norepi? Septic, cardiogenic, and one more. Neurogenic. Guys, I know I mentioned neosynephrine. Y'all just strike that from your, I'm not going to do it again. Unless you work in the neuro ICU, you're not going to give it. And I know I've had students say, hey, they gave me Neosic. I'm like, that's only at those places, and they have to have specific, we're not worried about neo. You're not going to see it in a lot of these hospitals. What is the first line for neurogenic shock? Norepi. So they bring a patient in, involved in a car wreck. Heart rate's 30. Blood pressure is in the toilet. MAP is 40. Their skin's warm and dry. Neurogenic shock, and now you just found out they can't move their extremities. What are you going to do? What's first line? Norepi. Yes, and very careful what? They need spinal immobilization. All this stuff does happen in tandem. But you see how we need to think about it based on your assessment. I don't know about this. I guess the vape pen exploded in your mouth or face. I don't know. What does it look like, and what does this look like? I know it looks a lot like respiratory failure. Guys, I'm not going to give you a question that you can't what? Differentiate. That's not fair. I've got to give you enough so that you can pick the right answer. What does this word say? It don't say a little. It don't say maybe a little bit. Tachypnea, anxiety, accessory muscles. What kind of adventitious breath sounds? That's upper airway. Crackles. What have you got in the alveoli? Fluid. This patient is what? Drowning. Your assessment. What do I need to look at? What does that stand for? Work of breathing. How hard are they working? What does that involve? Accessory muscle use. What's their O2 sat? Respiratory rate. Why is this on here? You better put them on the monitor. And I better have what in the room? Crash cart. Murphy's Law going to kick in. Everything that can happen bad is going to happen unless you're prepared for it. You need to send that tech, another nurse, bring the crash cart in there. Their MAP's too low and they're breathing 5 times a minute. I don't care why all these signs and symptoms. Bring the crash cart in there. Mind your what? The first sign of shock is you walk in and they're real anxious. They're wringing their hands. We need to start moving. It's a change in your assessment, and it might change your interventions. Listen to lung sounds. and you might get different tests. Here again, I need that ABG. So you need to call respiratory early. Different places do different things. Some places let nurses draw this. Guys, I have never drawn this, and I was working at Single. They're like, hey, go draw an ABG. I said, I ain't. I said, I don't know how to do that. And you can damage what? The nerve. I'm sticking this needle in an artery. Have you lost your mind? I don't know how to do that. I'm not doing it. They train the respiratory therapist there how to do it. Failure to plan on your part does not constitute an emergency on mine. Oh, we don't have a respiratory. You better call the main. If somebody is asking you to do something outside your scope of practice, what? Yeah, girl. And walking out. Don't do it. Don't let. Right? She said, "That's me." Treat the cause. You have to have a hair trigger with an advanced airway. If their O2 sat is that low and they're struggling that bad, it's probably not going to be long before they go into respiratory failure and respiratory arrest. You're going to have to put them on the ventilator. What are the reasons? That is the main one. You got to let their lungs rest, and hopefully what will happen? They will heal. And then we can take them what? Off the ventilator. That's the end goal. What kind of meds? What else if it's septic? Antibiotics, what else? If their pressure is low. If people have an infection, what kind of drug that somebody just said it? Steroids. Where's their cortisol level? Low. What's Decadron and Solumedrol? Cortisone. You're not going to see this at smaller hospitals. This is not the easiest thing to do. Why are we wanting to flip this patient over? Let gravity help you. Guys, sometimes, now we did it at Vandy in the MI a lot, but there would be 2 respiratory therapists, 5 nurses, 3 doctors, and God in the room, hopefully. Because you have to maintain that airway. Can you pull an intubation tube out? It is not hard. And if that's inflated, what's it going to rip? The vocal cords. I don't want that to be pulled out with 10 milliliters of air in it. I don't want it to come out anyway, because you can bet it's probably been in there for a minute and it might not be the easiest thing to get back in. Why is this important? Has anybody ever been around a cancer patient and they said, all I can eat is cake? And did you hear what the doctor told them? Honey, you eat all that cake you want. If you want some strawberry, I'll bring you the whole straw, and you can eat the whole cake. They're not eating anything else. I don't care what I get in them. It has to be something. If I can choose, what is it going to be? High protein, high everything. Everything. They don't have anything, but especially high protein. What does protein do? It helps the body to heal. We used to round with the nutritionists, that's the ones that had the doctorate and all them left. They would be spitting out some numbers, and I'm like, high protein, high carb. Yes, okay, good. It's not your job to know what's in there. It is your job to know we need to do this, and I need to have as few interruptions in this as possible, right? And don't lay your patient flat if they're getting by a feeding tube. But usually what is this given in? It's given in, and it needs to be in a central line. It's TPN, it's IV. Thank you. It is IV. But if it's not IV, we can put a what down? An NG tube, and you can feed them that way. Test. ABGs. Here again, why do I want just a plain film chest x-ray. For ARDS, it's different. This is a telltale sign. They don't call it shattered glass. What was... There's a word. But it looks very fibrous, or if you throw something at your car windshield, your car, it doesn't break. What happens? It splinters. This is not respiratory failure. Did I look on here and all this is whited out and I have big spots that are consolidated? No, that's pneumonia. This is widespread and it has that fibrous look to it. Chest, CAT scan. Why do I want this? I'm going to be looking for infection. Because what I need to do, I need to give them antibiotics. I'm going to give them broad spectrum, but then I'm going to do what? I need to narrow it down, so we need blood cultures. Does every patient that comes in sepsis initially, let's say they had a bad trauma and they got thrown out in the pasture in the cow poop, and they had an open femur fracture. Was that the initial problem? No. Cow poop does not belong inside. That's the outside thing. And I know that we're laughing about it, so they got to be taking the OR. They got to do a washout 511 times. But probably what's going to happen? They're going to get an infection. Then they're going to get an infection in the bone. And then what are we going to do? You're going to cut that leg off. Because if you don't, what happens? It just creeps up, and you're just going to have to trim up. I know. Because if you don't get up high enough, you didn't what? You didn't get the infection that's in the bone, and you're just going to continue to move up. This is just a picture I wanted to show y'all, and it's different for different places. We had a specific bed that can you leave them in that position? No. Because I need to do what? I need to flip them back over so the fluids will go the other way. And then I need to flip them back over so they'll go this way. I'm not asking you these numbers. Here again, I don't care about these numbers. I need to know that you can figure out that they're in respiratory acidosis just by how they present. A few of y'all have heard me say it's not carbon dioxide, it's carbon acid. Why do I say that? So we've got respiration and diffusion, right? Hopefully, CO2 goes out, right? It goes to the lungs. How's it transported in the bloodstream? Carbonic acid, right? We got too much acid to start off with. What does it pretty quickly break into? Hydrogen pH. The more hydrogen ions, the lower the pH. All right, we're adding here. Okay. What is this? It is a carbonate molecule. I don't know. What is the formula for sodium bicarb? I ain't even worried about that. What is that? Your patient is breathing 2 times a minute. What's building up? Carbon dioxide. What am I making more of? Carbonic acid. If I give them sodium bicarb, what am I giving them? More CO2, more bicarbonate, and it's going to make it worse. If you don't fix them breathing and you see I'm on my soapbox, they're respiratory acidosis, go get the sodium bicarb. No, I'm going to hide that amp. Respiratory acidosis does not get that initially. If you don't fix their respiratory status, it ain't going to matter if they're going to die, and you're just going to give them more building blocks to kill them. Did I say metabolic? I did not. That's usually amongst the first line treatments. Anybody ever seen anybody come in and DKA? They got that pretty quick. We'll add it into a bag of fluid and let it go in. Cardiac arrest, you know they hadn't been breathing out CO2. Respiratory, acidosis or alkalosis. Acidosis, because they got a buildup of carbon D acid, right? And I just completely forgot where I was going with that. If they're in respiratory arrest, you have to fix the airway to get rid of what? The carbon dioxide. Now, what kind of patients have respiratory acidosis? We've already talked about this. Buildup of carbon dioxide. Traumatic brain injury, spinal cord injury, the messages ain't getting through. Narcotic overdose. I'm breathing 2 times a minute. What am I not blowing off? Carbon dioxide. Their pH is going to be low. What's happening to the cells? They're dying. Aerobic to lactate is going to rise. Guys, y'all just answered every question. What's going to happen to potassium? It's going to go up. QRS is going to widen. Where's Allison? What was that? 8.6. And it just started creeping. I'm nervous. We went down there and treated it, and it went back down. Potassium shoots up. You're going to go into asystole sooner or later. You have to fix respiratory before you can attempt. A, B, C. I might not even get to C for a little while. I'm not going to give them sodium bicarb before I fix A and B. What kind of breathing does a patient with diabetic keto have? Kussmaul's. And guys, I tried to recreate this one time and I damn near fell down. So I'm not going to do it. 70 times a minute. What is their body trying to do? It's trying to save itself by doing what? If I get rid of more acid, CO2, then maybe my metabolic acidosis will improve. That's how your lungs kick in, and it's almost immediately. Are they in a respiratory acidosis? No. What is this? Metabolic, endocrine, diabetic, keto. I don't care about the diabetic. I don't care about, I do. Acidosis, Kussmaul's respirations. What are you going to do if you slow their respirations down? You're going to kill them. There is no ventilator in the world that can match that. I don't think we could get above a rate of like 25 or 30. And they literally were breathing 70 times a minute. How long can you maintain that? Not long. Even the youngest person in here, they're going to give out, decompensate, and die. Y'all stand up for a second. Jump around, do something, jumping jacks. I don't care. And I want y'all to know all of y'all are fired, especially the young folks. All y'all are fired. I had been fighting and struggling with Yusha to download these videos. Dr. Wilt came in and said, "Why didn't you put them on YouTube?" I want to choke you right now. I'm like, and one of the students like, I thought about suggesting, guys, if you have an idea and I'm struggling, come talk to me. This is stuff that I never thought of. And then I made it public. I mean, if you want to watch a chest trauma video, you just go right ahead. But Jess helped me figure that out, so everybody in God can't see it. But that's what's on there now. Yesterday, while we were in clinicals, there wasn't a whole lot going on. So I went in one of the ER rooms and we filmed going over the ventilator. You can hear the high pressure, low pressure alarm. It's the same. After you hear that alarm, what do you immediately need to do? Assess your patient to try to figure out what your interventions need to be.
Two buttons.
Now, hold on. There is 2 buttons you're going to mess with. And I'm going to reiterate this on the video. You are not going to touch this ventilator like I am. And we have somebody looking out the door to make sure the respiratory wasn't coming down there. You will not manipulate anything on here. But you need to know what some of these numbers are.
You will ever push on this ventilator or any ventilator the silence button and 100%. Now it will only do that for 2 minutes. And this is when you've got a critically ill patient
That's not the high pressure alarm or low pressure alarm.
Turn them over. You'll need to hit that button so that they don't have any bad
This is
outcomes.
I need you to know what happens if this goes south.
Yeah.
The numbers know.
Alright, so several of these numbers that you need to be able to recognize. That O2 is the FiO2, that is the inspired oxygen. So normal environmental oxygen is 21%, and that can be anywhere from 21% all the way up to 100.
Do we want to leave them at 100?
This is the peak
No.
positive end expiratory pressure. You need to know that number, and it is going to
This
be
is under
in
content.
orders,
Don't go to sleep.
that number, and I say this kind of with a little bit of hesitation, is never over 20. This is the respiratory rate, and that's how many times they're breathing per minute. This is the tidal volume. That's how much volume they're breathing in. And this is based off of ideal body weight, not the current body weight. Different ventilators call this different things. This is the
It says
high
peak
surface
pressure. I know you can't see that.
Peak pressure. So if this is hooked up to the endotracheal tube and this starts alarming, there are two things that can be going on.
Y'all can watch the rest of the video. Wait, I need you to hear the alarm. Sorry.
With that peak pressure, it's either too high or it's too low, and this will be
It's
set
not
with
that.
a parameter.
That one.
And that's the
Right
noise
there.
will
Did you hear that?
There's something going on with the vent that you need pressure. It's either too high or it's too low, and this will be set with a parameter.
I'll turn it down. Right there.
And that's the noise
Did you
will
hear that? That means
There's
high
something going
pressure,
on
low
with the
pressure.
vent that you need to look at and try to figure out what's
That.
wrong.
Is
If
it
it's
getting
peak
more
pressure and
insistent?
This is what it's set at, and it's now 60. That means that
Why am I telling you that that is the most important alarm that you will hear? It means what? We need to do something. Did I say respiratory therapy? Did I say the physician's assistant, nurse practitioner? You need to do something. As a student nurse, if you hear that and you go in the room and the ventilator's on the floor and it's disconnected, what are you going to do? Reconnect it? Or if you have no idea why that thing's alarming and it's flashing red, what can every nursing student, every nurse that's ever been created that has come through my class know what to do? Do you know how to run that machine? Nope. This is your student nurse ventilator right there. An ambu bag. Every one of you can do this without an order. If that thing's alarming and I don't know what's going on and ain't nobody down there with you, take that ambu bag, which should be right there, hook it up and bag the patient. If you can't bag the patient, you need to start yelling and screaming. And if the ET tube is on the floor, what are you going to do? Bag the patient. They got a mask. Y'all know how to do that. Does everybody in here need to come to open lab and practice this? Absolutely. Guys, we can go on every simulation mannequin and practice this. There is no excuse for you not doing that. When that thing alarms that alarm, you need to do something. Different things. And so if it starts doing that and you look up there and it's flashing red and it says high pressure alert, these are the things that cause that. What is happening to the ET tube? It's obstructed, maybe. They might be fighting the vent. How do we fix that? More sedation. They might be biting the tube. More bite blocking, more sedation. Guys, if you have got somebody intubated, and that's it, no sedation, no narcotics, you're going to walk in, and they are the color of Jenna's shirt, and they're fighting the tube, looking at you and biting it. I need some what real quick? And it's not just sedation. Their heart rate is 200 and their blood pressure is 170 over 110. What is wrong with your patient? They're in pain. Yes, we need some sedation, but I also need some narcotics. Guys, when they're intubated, there are things you need to tend to. If they're on the vent and you start seeing their blood pressure and heart rate do that, what's wrong? And then you walk back in and they are literally crying, but they're not responding. What is wrong? They're in pain. They are sick, and some of them is broke. They got 511,000 broke bones, and they're intubated. I've got this tube going down my throat. I don't really know what's going on. They're in pain. And if the sedation has worn off, they're also terrified. But they can't move because you have a paralytic drip going on. That's the definition of what? Torture. Y'all ever heard that before? High pressure. That ET tube might be clogged off. How do we solve that? Suction. They might not have had this to begin with, but does every patient that's been in a car wreck, that's been thrown out the vehicle, that's been run over by a horse, they might have a little pneumo, but then it develops what? A bad pneumo, and if they're on got the ET tube down, it's going to start saying what? It's obstructed. because the pressure is building where? In the chest. And as it turns into a tension pneumo, what's that pressure going to do? It's going to increase. If I have somebody who is burned circumferentially in the box, and it's that black, leathery, does not expand, and they're on the ventilator, what's it going to start doing? It's going to start screaming that you've got high pressures. Why? This is SCAR. You can't breathe through it. And it's going to constrict and make a tourniquet. It's increasing the pressure. What's going to cause a low pressure? You walk in and what? Your ventilator's on the floor. Or heaven forbid, you walk in and what else is on the floor? Your ET tube. Guys, equipment can fail. Can it have a hole in that cuff? And so it's not sealing, and your ventilator sees that as a low pressure. I figured out this morning that I did not put that other video that's got this mnemonic on it. If your patient is deteriorating and you don't know what's going on, and I don't care if they have a chest tube, I don't care if they've got an ET tube on the ventilator, I don't care what's going on. If your patient's blood pressure already just goes in the toilet, their MAP's dropped to 20, O2 sat is now 50, and you're transporting them to the x-ray from the trauma ICU, and they're really got all these broken bones and 4 chest tubes, and all of a sudden everything has gone in the toilet. It was me and 4 other nurses, and it was +4 panic. What did we start doing? Is the ET tube out? Is it displaced? What do you think the O is? P, pneumo. E, has your what failed? Equipment. Can your ventilator fail? Abso-freaking-lutely. And I'll talk about this one in a minute. So we're going down this. ET tube's in, the ventilator's hooked up, and we're pushing the patient, and they got 4 chest tube. One of the nurses looked down and said, "Oh my God, the wheel is on the chest tube." What did we immediately give this patient? A tension pneumo. I blocked off, I obstructed his chest tube. He just got it, and he has 4. How bad is that? It's awful. We removed the tire off of the chest tube, and it went back to the way it was. And I about passed out. This is for anything that you're working. Why do we do this? It gives you a systematic, because are you going to be scared? I was scared. I didn't know what was wrong with the patient. He wasn't like this before, and they're going to say that Shirley killed him. You have to work through these things, but you're still just critically thinking, right? What if it wasn't obstructed, it wasn't displaced, and I listen, and these are absent, and they weren't before? He's probably developed what? A pneumo, and it's turning into what? A tension pneumo. If they're on the ventilator, what if you were bagging them? What's it going to feel like? You cannot get the air in. What's increasing? Pressure. You're going to start seeing that trachea move. You don't have but a minute or 2. The R is new for me, but it makes a whole lot of sense. It's rigidity. There are medicines that are notorious for this. Does anybody know what it is? Allison, you can't answer. Ethan, you can't answer. It's the #1 drug overdose on right now. Fentanyl. And if you push, you can push it too fast if you want to. You're going to be bagging the patient for about 5-10 minutes. I had a girl that was orienting, and maybe this was my fault because I didn't mention this. We had a peds patient. He was 10. He broke his arm. He broke his leg. He needed some narcotics, and I bagged him for 15 minutes until it wore off enough. It will stop. But I was real nervous for a few minutes that I was going to have to do what? Intubate him. And did we create that problem? If you know, guys, they say push rates for a reason. They warn you for a reason. This medication might cause this. What do we usually give in conjunction with fentanyl? I said it has a potentiation effect. This one causes rigidity, not so much by itself, a lot of rigidity. We always give them together. Just because your patient's on the vent doesn't mean that doesn't happen. Chest wall rigidity, we on the vent. High pressure? Yup. You can't ventilate if it's rigid, right? This is not testable, but you're going to hear this. What's their RAS score? What does that mean? If you walk in and your patient that's intubated, and I ain't picking on them, they're just the ones I can reach. Your patient's intubated and they're looking at you and biting the tube and they try to hit you when you come in. What's their RAS score? They're trying to whoop you. If they're on the ventilator, what do they need? A little bit of sedation, a lot of propofol, and a little bit of paralytics maybe. Now, if you walk in and it's right here, what do we need to cut off? The sedation. You won't hear that down in the ICU. You won't hear that in the ER. That comes into play in the ICU. Why is that important at some point? It lets me start knowing what? That they're ready to maybe start coming off the vent. Guys, this ain't something we on the ventilator today, I'm walking and snatch the tube out and they're all hooked tomorrow. You have to wean them off. They have to start changing the settings on the ventilators. Complete reliance. A little bit less, a little bit less, a little bit less FiO2, a little bit less sedation. Hey, Mr. Jones, give me a thumbs up. All right, pull tube. They're that awake. And sometimes we think, oh yeah, this is good. We're going to take them off the ventilator, and they weren't really ready. What do we have to do? You got to re-intubate them and that happens. And it's not anything we did wrong. They just weren't quite ready, and we thought they were. Who decides that? Your patient. Hanks. How do we know they need to put on the ventilator? They're not breathing. Respiratory failure. If I've got respiratory distress with an unconscious patient, what is that? It's respiratory failure. You have to protect their airway. What if you have a horrible inhalation burn? It's going to swell shut, and you can't even give them a surgical cric at that point. You're going to lose your patient. Respiratory failure, severe circulatory shock, because sooner or later, what's going to stop also? Their respiratory system. These are the values I want you to know. How fast are they breathing? Because if it's set at 12 and they family in there, and you come back and it's 30, somebody's been what? Messing with the vent, and you don't know what to do, so take them off the vent and bag them. I need to know what? What is this? How much what? You're putting in there. So, I weigh about 160. Is the 500-pound patient's lungs any bigger than mine? No. Nope. So if I figure, what did I tell you we base ideal body weight? And I get my little phone out, my little calculator, so I know. But we don't do that. The respiratory therapist does that. Based on what? How tall you are, how much you're supposed to weigh. Now, do other things kind of go in that? If I weigh 600 pounds and I lay down flat, where does all this go? On top of my lungs. That doesn't mean you can jack the tidal volume up to 700. You're going to kill them. What are your lungs? They balloons. What can balloons do? And it scares the crap out of me every time it happens. I like to have this phobia. I won't blow them up because it terrifies me. Don't y'all go out and get some balloons. No, I'm just telling you right now. Tidal volume. What is this? Fraction of inspired oxygen. I told you it's 21 to 100%. We don't want to leave them on 100. Oxygen toxicity. Rate. What is this? Peak and pressure. What does that mean? Why do we add that? It makes what happen to those alveoli? What is this great in? ARDS patients. What's happening in their alveoli? It's filled with crap, and they're all collapsing. This peak end expiratory pressure, so that it gives the patient a breath in, and it comes out, and then it's a little burst of pressure, and it goes down in. This is what we want it to do in the alveoli and help it to expand where it needs to be. Now, can we put this number too high? Usually it's not above 20. I have seen an ARDS patient at 25, and was I nervous? Extraordinarily. What's going to happen? You're going to burst one or both lungs. Can this patient tolerate that? Absolutely not. That peak is a range, and it is set. You don't determine that. The physicians determine that. But if your peep was at 40 and your alarm starts alarming and you go back in there and your peep is now 10 and you can't hear breath sounds on one side, you probably did what? Ruptured their lung. A bad day. Yes, it is. And guys, I did not put this. I meant to have it on there. What is this? Peak inspiratory pressure. This is the high pressure alarm. This is also a range. So if it's going off and I set the range from 20 to 40 and it's 10, what do I suspect? The ET tube is dislodged, or I've got a what? Cuff leak. I go back in and it's 60. Maybe what? Obstructed with mucus, buhaki, I don't know. You might have a what? Kink somewhere. You have to trace that circuit all the way back. You have to know what the cause is of a high pressure alert, and you go in and do your assessment and work down that to figure out what the problem is. If we hadn't worked down that, we never would have saw the wheel on that chest tube, right? Everybody would have been running around going, what do we do? I don't know. So Allison gave me this here. Guys, this is just to help you. Causes of the high pressure. Pulmonary edema, pneumothorax. If they're biting the tube, it will make that high pressure alarm go off and go off and go off. Excess secretions, coughing, or a kink in the tubing. This is showing you what we want with PEEP. If I don't have enough, it's just going to stay what? Collapsed. If I have the perfect amount, the alveoli remain open. And that gives you more of a surface for what? That exchange. Oxygen diffusion, and it takes less pressure to expand the lungs. Do I want this? I do not. It's called barotrauma when you rupture the lungs. Again, this is telling you the things that are important. What's the two buttons you can push? Silence. And the 100%. And when do you do that? Guys, there are patients that are so sick they'll have a sign on the door. Do you know what it says? Do not move this patient unless you come see the charge nurse or they might write the nurse's name. Don't touch that patient if that is on the door. That means they are so unstable, they're probably going to code if you do that. I told y'all there's 2 or 3 times that you run the most risk of putting them in cardiac arrest. One of them was what? Moving them. The other one was what? Intubating them. This is just another one that is off Simple Nursing. Here again, high pressure, biting the tube, kinks, excessive airway. We've already talked about that. This is just showing you you see I blacked out everything else. I don't care. Not that this is not important. It's not important for us. I want to know what the rate is. I want to know what the PEEP is in case somebody's in there messing with a vent. I want to know what FiO2 is. You ain't going to have a 700. I don't know where that number came from. And I want to know what the peak pressure is set at. But the thing about the peak pressure, I have to know what? I have to know the range. Because the ventilators at Tenova, if it had a high pressure, it is flashing red and it says high pressure. Do you think every ventilator does that? No. Whose fault is this? It's ours. What causes this? You're not doing oral care, and you're not doing what with the Ballard? You're not suctioning, because you got an ET tube. That's the gold standard, right? You can you can throw up all you want to. It's not going to aspirate. It's got that little cup. What sits around here? Secretions. Anything that lays stagnant grows moss. This is growing moss right here, and it includes bacteria. Yeah, I know it. All it takes is suction. That's it. This means we did not do our job. And now who owns this patient's hospital bill? We do. Bed sores, ventilator-associated pneumonia is our fault. Guys, it's not hard. Elevate the head of the bed. DVT prophylaxis, that's because they're not moving. Daily oral care with, and guys, those things don't taste very good. Have y'all ever put one in your mouth? It's supposed to be minty flavored. No, it's not. Why do we put patients on the vent sometimes? Y'all already said it, just to let their lungs rest. But you can't just leave them on it, because they might not ever start breathing again. So we have to start weaning them off the sedation sometimes, so that we can get them off the vent. These are just the ABG values. This is the mnemonic that we talked about. It's just going over it. Any questions? What time do y'all get out of here?